Hi everyone, my name is Chau and I'm a student at the University of Ottawa. Before I begin, I'd like to thank the Beyond Sciences Initiative for allowing me the opportunity to present at today's conference. The topic I will be presenting is the global burden of surgical disease, an analysis of inaccessible surgical care in low and middle income countries. The aim of this presentation is to raise awareness on the lack of surgical interventions in low and middle income countries, to understand the current hurdles towards accessible and universal surgical care, and to give recommendations based on successfully implemented models. The global burden of surgical disease. Worldwide, 4.8 billion people do not have access to safe, adequate surgical care and anesthetic management. Of the 240 million surgeries performed every year, 75% are performed in the wealthiest nations, while the poorest countries only receive 4% of these operations. The provision of surgery has been essential in advancing medical achievements and human health. In 2010, about 33% of deaths worldwide were from conditions needing surgical care. This surpasses the combined total of deaths from malaria, tuberculosis, HIV/AIDS. This is a diagram depicted by the World Bank demonstrating the 44 essential surgical procedures in 7 broad categories: dental procedures, aesthetic and gynecological, general surgery, injury, congenital, visual impairment, and non trauma orthopedic. Um, as a note, nearly 1.5 million deaths and 77 million disability adjusted life years could be prevented every year if 44 of the essential surgical procedures were provided. Surgery is considered the neglected stepchild of global health, yet it remains one of the most crucial health services to an independent healthcare system. But there are obstacles to universal and healthcare, universal surgical care. So these are financing, infrastructure, workforce service delivery, and management. The first is finances. There is an aim, or there is an estimate to aim towards a 5% total gross domestic product for health-related spending in order to overcome resource deficiencies for low and middle income countries. But this has been quantified in reference to the worldwide 5.5% average GDP spending on healthcare, and as well as the fact that the monetary value of GDP varies greatly between countries. In addition, most countries use out of pocket payments as a primary method of compensation, so it's difficult to quantify a country's true GDP expenditure for health related spending. Regardless, there have been efforts to procure finances to low and middle income countries. And in particular, the Developmental Assistance of Health, the DAH, is a form of financial assistance from foreign nations to developing nations to improve the health related sectors. So, since its introduction in 1990, the DAH has been a major source of funding for developing nations. In 2012, approximately 28 billion was contributed by the DAH, which the majority of the finances were directed towards HIV/AIDS, tuberculosis, malaria, maternal newborn health, and health research. And so it has allowed for developing nations to make great strides in developing their healthcare system. However, a criticism of the DAH is the siphoning of government health service funds towards domestic services. So, although healthcare is essential to the welfare of a country, other matters may take priority, such as the economy or education. In addition, the Ministry of Finance has the ultimate control over DAH funds and can redirect the funds at their discretion. So, therefore, although there are large financial contributions to low and middle income countries, there still remains an absence of expendable funds towards surgical healthcare services. The second barrier is infrastructure. Most hospital infrastructures are not equipped to deliver surgical care, and this has had a negative impact on population health. In order to ensure safe and adequate surgical care, standardized equipment and operating rooms need to be sterile and effective. So, for instance, in Uganda, out of 14 hospitals, only 4 had a proper waste disposal incinerator, only 8 had access to oxygen, and only 1 had a working sterilization, autoclave sterilization machine. Similarly, in Afghanistan, only 1/3 of hospitals had access to blood banks. Even more essential medications and personal protective equipment are out of stock because of lack of funds or lack of management. Um, Furthermore, 95% of low and middle income hospitals receive their equipment through donations, which are often missing necessary components. They're often difficult to repair or they're out of service. Uh, Low and middle income countries spend on average $6 to $12 on medical equipment. And now, this aligns with 90% of the world spending $6 to $12 on medical equipment. And this is in stark contrast to developed nations spending upwards to $290 on medical equipment. So, the cost of medical technology still serves as a substantial barrier to accessing surgical care. The last barrier is the lack of medical expertise and personnel in low and middle income countries. The lack of healthcare management systems are often attributed to the economic and financial circumstances. So, reducing the financial gain can affect the incentives for healthcare providers to respond to patient demands as well as to improve the quality of service. A stemming issue is the availability of trained physicians, for instance, anesthesiologists. In Rwanda, there are 50 surgeons for 11 million individuals, and in Burundi, there are 15 surgeons for 10 million individuals. And as such, these patients are often referred to untrained medical personnel. Deficits in the workforce can be based on a number of factors. This can be due to poor remuneration, lack of postgraduate training, it can be due to lack of facilities, it can be due to poor retirement provisions, or civil unrest. Another major burden affecting the healthcare system and the education system is the brain drain phenomenon, where medical professionals from developing countries migrate to developed nations. In Africa, almost 23,000 qualified medical professions immigrate for better remuneration and working conditions. So, this global shortage of physicians and trained medical providers poses a significant threat to potential patients and as well as for patients in rural areas where access to surgical care is already limited due to cost of transportation, rehabilitation costs, due to lack of facilities or the lack of medical personnel. Now, the question that arises is surgical care cost effective? The ultimate concern for policymakers in low and middle income countries and abroad is whether surgical care is cost effective. Several studies agree that implementing surgical care with other interventions is complex and expensive, but they do suggest that it is attainable. The disability adjusted life year, the DALI approach, has been used to analyze the cost effectiveness of surgical care by comparing the monetary cost to avoid the loss of 1 year of healthy life. In the assessment of 112 interventions, they found that surgical interventions all costed less than $1,000 to avert a disability adjusted life year. And examples of these surgeries are C-sections, cataract surgeries, as well as emergency C-sections and cleft lip repair, which range from $10 to $300 per disability adjusted life year averted. In comparison, these are similar in cost to current interventions such as oral rehydration therapies, bed nets for malaria, as well as vitamin A supplementation. Now, apart from the developmental assistance for health, there are the existing strategies are humanitarian aid missions. So these are provided to areas with a high burden of disease. Organizations such as Operation Rainbow and Mercy Ships have been effective in providing surgical care, and the success of their missions have been attributed to overcoming the scarcity of resources as well as overcoming language and cultural barriers. For other organizations, medical missions were hindered by financial and equipment constraints, language barriers, and the complexity of the procedure. So, for instance, in several organizations, simple surgeries such as tonsillectomies have very low complication rates, um, whereas other surgeries such as hernias and cleft lip repair have much higher complication rates. Hernia operations in sub-Saharan Africa um, from medical missions have a mortality rate of 1%, which is 20 times higher than in higher income countries. It's also been a struggle to evaluate the long-term effectiveness due to the lack of patient follow-up and due to the failure to implement a short-term approach. In addition, while humanitarian outreach has provided medical advantages, it focuses on specialty care for injuries and warfare, leaving a gap for congenital and acquired deformities. From a holistic perspective, inaccessible surgical care is a multifaceted social, economic, and political issue, but global surgical care can be achieved. Compiling several studies, there have been recommendations to focus on 5 key factors, which are infrastructure, workforce, service delivery, financing, and information management. The broader recommendations for low and middle income countries are to enhance the management systems, to provide telemedicine, to provide training and education, to incorporate rural support, to identify and allocate resource and research priorities, and to create a national budget for healthcare. Now, while these recommendations can't be implemented in a short time span, these are set in place as a starting point for local and foreign policymakers. From a more community perspective, certain projects aspire to solve minor issues. So, for instance, Remedy, which is the recovered medical equipment for the developing world, they aim to promote the recovery of unused medical donations and its cost effectiveness. So, in contrast to unsalvageable donations, these donations can be unused and they can range from something like gloves and syringes to operable ambulances and x ray machines. So, in conclusion, surgical care is an essential service that is required to achieve a comprehensive healthcare system. And despite its importance in achieving equitable health, there still remains considerable disparities in access to surgical services. And although there is an urgent need to address the implementation of surgical services, there are financial and political obstacles that have made it difficult to actualize. The impacts of these challenges have accumulated into the current state of affairs regarding medical equipment, infrastructure, and trained service providers. Regardless, the successes and shortcomings of the developmental assistance for health and the humanitarian relief missions have been explored, and both have tremendously contributed towards progressing towards universal surgical care. Now, with strategic recommendations and awareness of the issue, the provision of surgical care can make great strides in overcoming the global burden of surgical disease. That is all. Thank you very much for listening.